Okay, so this is video 4 for pulmonary function testing, and we'll start with talking a little bit about vital capacity. And vital capacity is directly measured from spirometry, which means if you do a PFT test, then you can go ahead and measure the vital capacity directly from that. So to get a vital capacity, you have the patient do some normal breathing first, and then once you get a pattern of normal breathing, then the patient takes a big deep breath in as much as possible and then exhales fully, pushing all of their air out. And it is the maneuver we use to do what's called a flow volume loop. And there's some flow volume loops here on the bottom of the slide. So if you follow my tracing here, the patient's going to take a deep breath in and then blow all their air out, keep going, keep going, keep going, keep going, and then they'll take another deep breath in. So that's how a flow volume loop would look, and we'll talk more about flow volume loops in the next few slides as well. Oops. So let me switch pen colors here and do that again. So for a vital capacity, we have the patient take a deep breath in and then blow all their air out, keep going, keep going, keep going, keep going, and then another deep breath in. All right, so there's two different types of vital capacities. We can do a slow vital capacity and a forced vital capacity. So for a slow vital capacity, you can do that with a Wright's respirometer because you will not break the veins. You can also do it with a PFT machine. However, most of the time, if you're using a full PFT machine, we do a forced vital capacity. But a slow vital capacity will avoid the generation of increased interthoracic pressures. Again, forced vital capacity, normally it will be the same volume as that found in a slow or non-forced vital capacity. You do have to give these patients careful instructions, demonstration, and coaching to ensure that the patient's efforts are the best possible. And they do have to have at least 3 proper efforts need to be obtained to assure that you get the best test. And the highest forced vital capacity, an FEV1, which is forced expiratory volume in 1 second. Forced expiratory volume in 1 second. And this is going to be an important part of the PFT when we start looking at determining if the patient has an obstructive component or if they have a restrictive lung disease. The tracings for a forced vital capacity when you're doing a flow volume loop should be smooth without any coughing or other interruptions in the patient's effort. Encourage the patient to try to push as much air out as possible as the end approaches. And current guidelines require that the patient keep pushing air out so that the total effort lasts at least 6 seconds. So PFTs are hard to do for people that have normal lung functions, and even harder if they do have some sort of lung abnormality. So you really have to do good coaching and kind of show the patient how you want them to breathe. And that expiratory effort does need to last at least 6 seconds. So if you do this at home, you can kind of take a deep breath in and then blow all your air out as hard and forcefully as you can and have it last at least 6 seconds. It's a lot harder to do than what people think, but we have to get all of that air out of their lungs that they are able to exhale when we're doing the forced vital capacity. And then after they get all of their air out, they take forcefully and quickly exhale all that air out, and then they do a maximum inspiration at the end of that forced vital capacity or flow volume loop. The forced vital capacity, it will be less than the slow vital capacity when airway collapse and air trapping are present. And the disease we most commonly think of with air trapping is diseases like emphysema. And that's because of increased interthoracic pressures and airway collapse during a forced vital capacity maneuver. And so then less air is expelled because all that air gets trapped that's down below the obstruction. A measured forced vital capacity that's at least 80% of that predicted is considered to be within normal limits. And forced vital capacity does decline with age. It will be low on restrictive problems and with chronic obstructive lung disease. All right, so flow volume loops are measurements of inspiratory and expiratory flows and volumes. They do record flow against time. So flow will be on the vertical axis and time will be on the horizontal axis. Patients with obstructive lung diseases will show low flows, and the test is performed by having the patient maximally inspire followed by a single forced exhaled vital capacity. So FEVC, which is forced expiratory vital capacity, and then it's followed by a maximum inhalation, or an FIVC, which is forced inspiratory vital capacity. The following things can be determined by using or doing a flow volume loop. You can get a vital capacity, the patient's tidal volume, IRV, ERV, or inspiratory reserve volume and expiratory reserve volume. You can get an inspiratory capacity. You can look at peak inspiratory and expiratory flows, forced inspiratory flows, forced expiratory flows, and forced expiratory volumes. The major advantage of a flow volume loop is that they give a quick visual impression of the general disease category, and we'll kind of go over the different looks of forced vital capacities. So these are some different flow volume loops. The first one there is a normal flow volume loop. So again, we have, let me change the color here. So again, we have the patient takes a deep breath in, blow, 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 blow until they can't get any more air out, and then another inhalation. So if you look here, this line is a normal flow volume loop. That's what it should look like. And remember, flow is over here and volume is down here. That'll be important. So if we look at restrictive components, this middle one is a restrictive component. Let me change my color again. So this middle one that I'm drawing in purple is a restrictive component. Take a deep breath in, blow, 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 blow all your air out, and then inhale. So patients that have restrictive components do have problems with volume. So you'll see that their flow, the top of this area here, is pretty normal, but it doesn't come out as far on the volume axis. So this restrictive one is kind of tall and thin. Restrictive patients, they do have problems with their volume. And then if you look at the obstructive components, I'll make that blue. That's the third one here. Patient takes a deep breath in, blow, 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 blow. Another deep breath in. That's obstructive. And obstructive diseases have problems with flow. So you'll see over here on the volume side, we kind of reached a normal volume, but up here, we did not reach a normal flow level. So again, restrictive components, they have problems with their volumes. Obstructive components have problems with their flow. And when I say volume with restrictive, I'm more talking about like capacity. So again, obstructive diseases have problems with their flow. Restrictive diseases have problems with their volume or capacity. These are just some flow volume loops that talk about all the different obstructive diseases, and we're really not gonna get into those, but you can take a look at them. The first one is a normal flow volume loop. The second one is early small airway obstruction. The third one is pretty typical what you're gonna see on somebody that has chronic obstructive disease. So if they've had like chronic emphysema, chronic bronchitis, things like that, they'll fall into that flow volume loop. Fixed large airway obstruction is next, and then variable extrathoracic large airway obstruction. And then the very last one, again, this is typical of a restrictive disease. It's kind of tall and skinny because, again, they don't have any problems with flow. Their flow portion is up here, but they do have problems with their volume or capacities. So again, just some things that I wanted to reiterate. Obstructive diseases are characterized by decreased flow, especially on expiration. The expiration got kind of cut off there, so if you want to write that in, it's characterized by decreased flows, especially on expiration. And restrictive diseases are characterized by decreased lung volumes. So let me go back to obstructive again. Obstructive, remember, is this third one here. Problems with flow. Our flow doesn't reach where it needs to be, but our volume is fine. Restrictive diseases is this middle one. Again, it's the tall, skinnier one. We have no problem up here with flow, but we do have a problem with capacity or volume. And I'm not sure why I keep getting these errors, but I'm going to go ahead and stop there, and then I will reopen and continue on.